Unruptured ectopic pregnancy. Investigations. First, we will do transvaginal sonography. If ectopic is confirmed, you can see gestational sac plus yolk sac with or without cardiac activity in the fallopian tube. Gestational sac plus yolk sac plus cardiac activity in fallopian tube. Suspicious sign on USG will be adnexal mass. Adnexal mass, as mentioned above, it is the most common and most important sign. Then comes the Bagel sign. Bagel sign is gestational sac only. There is no yolk sac or cardiac activity in the fallopian tube. You can only see the gestational sac, that is a single circle. Now ring of fire appearance. Ring of fire appearance is main. Then comes the empty uterus. First we had done TVS, now we will go for beta HCG. In beta HCG we will check. If the level is more than 2000 IU, it will be seen on TVS, and it will be more than 6500 international unit. We can see it on the trans-abdominal sonography. Now, algorithm to diagnose unruptured ectopic. So, how will you diagnose? First is you will do TVS. If you see gestational sac plus yolk sac in the tube, you will go for medical management. And if suspicious sign is present, that is dissolve sign, adnexal mass, Bagel sign, or ring of fire appearance, we will check beta HCG. If beta HCG is more than 2000 international unit, then we will repeat the transvaginal sonography. And if once the ectopic pregnancy is confirmed, we will do medical management. And if the ectopic pregnancy is not confirmed, we will again repeat the beta HCG after 48 hours. If the value of beta HCG is less than 2000 IU, we will repeat beta HCG after 48 hours. अगर 48 hours के बाद if the value increase by more than or equals to 66%, then it is likely viable intrauterine pregnancy. अगर value बढ़ रही है but it is less than 33%, तो likely ectopic pregnancy. If it decrease, then it will be the case of abortion. Now, important point is first investigation or investigation of the choice is always TVS. Gold standard is laparoscopy. You can also do serum progesterone or coldocentesis, but we will never do hysteroscopy, hysterosalpingography, or colpotomy. Now, diagnosis. Diagnosis is by the coldocentesis. Coldocentesis is aspiration of fluid from the pouch of Douglas. So, if you will get clotted blood, it means that your needle had entered any blood vessel. And if you will get unclotted blood, it means the cases of hemoperitoneum. Now in USG Doppler, we will see ring of fire appearance. And the most common finding is adnexal mass. It was also most important sign. How will you manage the case of unruptured ectopic pregnancy? First is medical management. Best treatment is with methotrexate. Dose will be 1 milligram per kg. Intramuscularly single dose. Now requirement and criteria. So absolute requirement is patient should be vitally stable and family should not complete. Then other can be ectopic size less than 4 centimeter, beta HCG less than 5000 international unit, and no cardiac activity. If any of the criteria does not meet, we will go for laparoscopy surgery. And if it meets, we will give them methotrexate 1 milligram per kg intramuscularly single dose. Now treatment algorithm. On day 1, we will give baseline beta HCG plus injection methotrexate. Beta HCG will be checked again on day 4 and day 7. If it decreases by 15%, that is medical treatment is successful and no further treatment is required. If it decrease but less than 15%, so we'll repeat methotrexate. We can give maximum to 3 times. If there is no success, the patient is still the same, it means that medical therapy had failed. So we will go for laparoscopic surgery. Surgical option. If family is complete, we will do unilateral salpingectomy. And if the family is not complete, we will do linear salpingostomy. In unilateral salpingectomy, we will cut the fallopian tube and we will remove the ectopic part. And in the linear salpingostomy, we will make a linear insertion and just remove the ectopic part and then suture back the insertion part. Thank you.